Why does prostate cancer treatment often begin by blocking male hormones? Prostate cancer is one of the few cancers that depend heavily on hormones to grow. That hormone is testosterone. Hormonal therapy, also called androgen deprivation therapy or ADT, works by starving cancer cells of this fuel. So what exactly is hormonal therapy and how does it work inside the body? What does hormonal therapy actually do? Hormonal therapy does not remove the prostate. Instead, it reduces or blocks testosterone, which prostate cancer cells depend on to survive. According to NCCN Guidelines, hormonal therapy is a cornerstone treatment for high-risk prostate cancer, very high-risk disease, metastatic prostate cancer, and as a combination with radiotherapy. But how do we reduce testosterone? With medicines or surgery? Is surgical castration still used today? There are two main ways to lower testosterone. Medical castration, most common. LHRH agonists, leuprolide, goserelin. LHRH antagonists, degarelix, relugolix. These drugs suppress testosterone production and are reversible. Surgical castration, bilateral orchidectomy, permanent, one-time procedure, still effective and low cost. According to recent NCCN guidelines, medical castration is preferred, mainly due to reversibility and psychological acceptance. But surgical castration is still a valid option when cost, compliance, or access is a concern. But hormonal therapy rarely works alone. What happens when we combine it with radiation? Why do doctors combine radiation with hormonal therapy? For intermediate risk, high risk, and very high risk prostate cancer, NCCN strongly recommends combining radiotherapy with hormonal therapy. Duration matters. 4 to 6 months for unfavorable intermediate risk, 18 to 36 months for high and very high risk. Large randomized trials show this combination improves survival, reduces recurrence, and improves local control compared to radiation alone. But hormones today are more advanced than ever. What are the newer drugs? What are the newer hormonal treatments? Beyond standard ADT, we now have next generation androgen targeting agents: abiraterone, enzalutamide, apalutamide, darolutamide. These drugs block testosterone signaling more completely and are now recommended by NCCN for advanced and metastatic disease, often early, not as a last resort. But blocking hormones also affects the rest of the body. What are the side effects? What changes should patients expect on hormonal therapy? Common side effects include hot flashes, fatigue, loss of muscle mass, weight gain, sexual dysfunction, bone thinning, risk of diabetes and heart disease. These effects are real, but manageable when anticipated early. So how do patients prepare and protect themselves during therapy? How do we reduce side effects of hormonal therapy? Before starting therapy, baseline bone density, blood sugar and cholesterol check, cardiac risk assessment. During therapy, regular exercises, calcium and vitamin D supplements, bone protective agents when needed, PSA and testosterone monitoring. Hormonal therapy works best when treatment and lifestyle go together. But how do we know if hormonal therapy is truly working? When does hormonal therapy succeed and when does it fail? When hormonal therapy works, PSA falls and stays low. But sometimes PSA doesn't drop enough or rises again, means recurrence. I am Dr. Shankar. Stay informed, stay proactive, because understanding treatment gives you control.